वो देना ईयरफोन मेरे ईयरफोन छोटा सा डब्बा है ना ईयरफोन वो ऊपर पड़ा है कि कहाँ पड़ा है चश्मे के पास पड़ा है क्या
Some backside, some noise is there. Please mute yourself. And who are answering today?
Sir, myself, Ajinkya, sir.
Dr. Ram.
Ajinkya and
Yes, sir. Rahul.
Ajinkya, you are answering and
Rahul, sir.
Me,
Rahul, na?
Rahul. Yes, sir.
Oh, okay. Rahul.
Gaurang Shah, sir, good evening, Mahendra here.
Mahendra,
Sir, today
please,
class
you are required. Bye.
actually topic is endourology mix, but what we discussed last time, it was just to this thing answer the
No.
queries.
I'll tell you. Mahendra, what has happened
Hmm.
that we had asked everyone to send their questions. No one has sent a question. But in this is just a presentation. We are not doing much. We are just showing them the X-rays and other things. But in that also ask or their queries, and we will keep it open. If someone wants to ask about the malignancy, also we'll keep it open.
Okay.
Because, for example, we are doing prostate. So in prostate also there will be malignancy.
Yeah. So, sir, is it possible malignancy थोड़ा पहले कर सके तो?
हाँ तो पहले तो first what prostate only.
अच्छा, ठीक है.
Excuse me, there is some out. Please.
Sir, can you mute all? Sir, you are the host.
Okay, Mahendra, you can.
Yes, sir.
Yeah, you can now. Yeah, tell me. So first two cases are that only, which
Okay.
is like, we have got all the things done. So it will be like a CA prostate also. So you can ask them and whatever it is. And then
Okay.
we'll finish it fast. Hi,
Okay.
Hiren. Missing you. You're mute. You're muted. I have to make you 1 second, huh?
Good evening, sir. Good evening.
Good evening.
Bye, good
Okay.
evening.
So we have got Dr. Hudedar also. Abdul Salam has joined.
Udedar sir, Maheshwari sir, both are there, sir. We can start actually.
Yeah, we can start, but let him join now to show the slides.
Yes, sir. Yes, sir.
जल्दी जल्दी करो ना तुम लोग, पहले 10 मिनट पहले करना चाहिए यार. Yeah, Swastik is just joining. So once he starts his slides, okay, we'll start it. So all those who have joined, okay, if you want to ask any question, I will unmute you. So you can raise your hand also. One of us will unmute you and you can ask your question. Please clear all your queries today only, so that whatever it is there, so that in exam you don't make any mistakes.
Can we start, sir?
No, I'm just waiting for Swastik to start the slides.
Yeah.
If there are any questions, they can always ask you now
Yeah.
also. So Ajinkya, if you have any question,
Yes, sir.
Dr. Mahendra Pal Mahendra is already there. You can just ask him.
Any onco-related questions? Sir is saying we can start talking. Ajinkya,
Yes, sir.
any of you all have any questions
Even in the
regarding last discussion?
उन्होंने किया है ये.
Okay, I think
Sir,
slides have started. We can start.
So Rahul,
Yes, sir.
now if your friends are also there, if they already joined, you please
Yes.
tell them. Okay, we can unmute them and you can ask them to join us, so they can also ask question. Here we are not interested in discussing the full case or whatever it is. It is in exam, what are the things which are given, and on that, if you have any queries,
Okay.
okay. Here we are not there just to discuss what is the diagnosis, what are the investigations required. Yes, we have got everything. But
Okay, sir.
in this, mainly we want questions from your side, that you might have come across so many other exams, mock exam, where the questions are asked and you don't know how to answer those questions. You know the theory part, but you don't know how to answer those questions. So today is a time.
Okay, sir.
Fine. For example, CT scan, whether you should do before or you should do after the diagnosis, or any case like CA testes or CA bladder, when you should do in the exam. If the examiner asks you, then how to answer it. Because we have got now Dr. Maheshwari, who is now free. He will be there, and Hiren is there. Gite sir might have joined, I don't know. So please, okay. So tell your friends also.
Yes, sir. Yes, sir.
Okay, fine. So as soon as if you got last 4 cases, we had all CA upper track. So if you got, and the bladder also. So if you got any question related to that of the last time, then please ask Dr. Mahendra. Yeah, someone has asked the question.
Yeah, so there was a study which compared carboplatin and the cisplatin and which found similar result compared to less side effects. So that's why carboplatin is used, because cisplatin has more side effect profile compared to carboplatin. So when a single drug should be used, it should be carboplatin, but in combination should be with cisplatin in seminoma.
Ganesh Bhai is also joined. So we have good
Yeah.
faculty.
सर थोड़ा
Yes.
मैं घर पहुंचा हूँ
Yes.
मतलब अभी फिर भी ज्वाइन करके आई ड्राइव होम इन 10 minutes.
Yeah, no worries.
No problem.
No problem.
So
I am there.
I'll just brief you. First two cases are the prostate cases. Okay, even though they are endourology cases, it can
Like-
mimic malignancy also. So we have got all the
No
investigations.
problems. We'll
So they can ask you about all these questions and you can answer them. And after that, there are two cases of urolithiasis. I will be happy if you continue because, of course, you also have done so many cases
नहीं I'll
earlier.
continue. No problem. टाइम है मुझे सिर्फ मैं लेट हो गया हॉस्पिटल में.
No problem. Huh? Okay. Swastik, can you start?
So for
Good evening, sir. Yes, sir. First case. Let's start.
Yeah, please start.
A 74-year-old male patient present with the complaint of frequency, urgency, and nocturia.
Yeah, go ahead. You just finish your history.
No history of hematuria, dysuria over last 6 months. History of taking this tablet amsulation for the same. Showed improvement in symptoms initially.
I just want to interrupt over here. Why did you mention last 6 months? It was
चल मैंने
it was there before that. Better to say no history of hematuria, dysuria. That's all. No
Yes,
need to
sir.
mention any time.
Yes.
Hmm.
No
So all
history
of
of
you just
instrumentation in the past.
Again, the first line. There should be some timeline on the frequency, urgency, nocturia. There should be, you have a timeline, maybe 6 months, 1 year, like that. And then
Yes.
it is relevant mentioning timeline in second line. Okay?
Okay.
Go ahead.
No history of facial edema, breathlessness, lower limb edema, no comorbidities. On examinations, patient conscious oriented, vitally stable. Per abdomen, no obvious palpable lump or no organomegaly. On DRE, no fissure, fistula, grade 3 prostatomegaly, firm and non-tender. Mucosa mobile, no blood on finger. One suspicion nodule palpable on the right side of the gland.
Okay. So in this examination for the grading, you should know sonographic grading and the this PR grading, finger guided finger PR. Okay.
Yes, sir.
You
Yes.
should know that these two gradings. Okay. Next. And nodule of the size, size of nodule also to be mentioned if it is there. You cannot just
Yes.
leave like nodule is present. Okay.
Yes.
Okay.
And firm, hard. Okay, that is fine. Okay.
Next slide, sir.
Hmm.
Hemoglobin was 11.8. TLC was 7,450. The platelet was 238,000. Serum create was 0.76. And PSA was on 22nd 7th 4.5. And on 2nd January 24, it was 7.2.
Okay, go ahead.
Go ahead.
So this is the uroflowmetric graph, sir. And report.
Okay. Then show the sonography also. We don't have sonography.
No, sir. Sonography.
No, but sonography was there. But this is the first case, na?
Yes, sir.
Okay. Anyway, so Ajinkya and Rahul,
Yes,
as you
sir.
know, so like we have specifically mentioned two PSA reports.
Yes, sir.
Okay. So now how you'll go about if the PSA is rising? It is showing that it is rising. Patient has already taken antibiotics.
Okay. Sir, I would first do a USG, and after that, sir, followed by I would like to do MP MRI in this patient, sir. And depending upon the report, I would plan my further management, sir.
Serum PSA is rising in 3 months. Am I right?
Yes, sir.
Just near double.
Yes.
So you are not suspecting infection.
So sir told actually that he has
We had
taken
already given the antibiotics, and
antibiotics.
after that also we have done this PSA.
And
Okay,
sir,
so it should be there in the exam. If this history is not there, then you can keep urine culture in your list of investigation.
yes, sir, urine routine microscope.
Yeah, if there's no bacteria, then you can avoid using culture, but routine is okay.
Okay, sir.
And
So I think, your question
sir.
should have been, okay, sir, whether we should ask about urine culture and sensitivity in this case or not. See, you just start thinking and ask what are the things are not done, whether they are required or not. Any question, any investigation, management. That is what we want. You know.
Yes, sir. So two, three things, sir. One is history of any recurrent UTI or something in the past, like the 6 months when he's developed this symptoms. And second is any history of any instrumentation or surgery in the past if he has undergone.
Yes.
Yeah,
No,
but
he has not undergone.
yeah, because you will not be retrograde. You cannot ask after having serum PSA 4 ka 7 ho gaya, then in instrumentation. It should be in the history.
Yes, sir.
Okay. Yeah. Okay, fine. Uroflowmetry, QMax 12.6.
12. For
Okay.
his age, it is
Average.
average.
Okay.
And sir, PVRE actually has not been mentioned, so that is one thing which is pending in the USG post-wet dressing.
Yeah.
Next.
So this graph you consider as a normal, or you think that it is obstructed or it is symptom? Means
So
Dr.
the graph is
Maheshwari
showing
is there.
Yeah, I'm
the
there,
graph
sir.
is showing some marked hesitancy, and the though it is bell-shaped, but the average as well as Qmax are very low. Looks like an obstructed flow pattern, sir.
You said hesitancy. Uroflowmetry, how can say hesitancy?
So the graph has started after some time, so that's why.
Okay. And there may be also some tubular dribbling also last May, I think.
Yes, sir. Yes, sir. Long period he has taken for avoiding the volume also.
Prolonged voiding.
Prolonged.
Okay.
Actually, I can't see how much he has voided the volume amount.
So it can only be
170.
obstruction. Anything else?
170. Could be obstructive, sir, or could be we cannot differentiate whether it is outlet obstruction or because of the detrusor under activity. We'll have to.
Yeah.
This could be the two possibilities, sir.
Yeah, always. Yeah. Okay.
Okay.
So next, what you want to do?
So considering a nodule on the right side of the prostate and the rising PSA, and if there is the urine routine is having no any pulse or no WBCs are normal, like to go ahead with an MP-MRI for this patient, sir.
Why
No,
not
any
biopsy?
other question? Any other question is coming in your mind? Whether you want to ask us whether, sir, can we wait? He doesn't have much of the post-void vascular urine. Graph is not very poor flow. His gland is, I think, enlarged. It is about 70 to 80 grams. I think 90 grams. It is. Sonography was showing 90 grams. And PSA, can we wait for another 3 months and can repeat PSA after 3 months? This is a time to ask you questions.
Sir, actually, as he's having a suspicion nodule in the prostate, sir. So that would be one of the indications to do a MP-MRI in this case. And we have a rising PSA also, sir.
Yeah. So suppose if the nodule is not there, Mahendra, suppose the nodule is not there, and this is the only finding, the question sometimes arises is that can we wait because his flow is not very poor? And if the patient says that otherwise I am happy, I don't have any other symptom, or with the medicine I have improved,
So
whatever
again,
given.
Yeah, so again, sir, it will be better to rule out other causes and infection, other things, yeah. And we can also repeat serum PSA after 2-3 weeks. If it is it is same or rising, then MP-MRI is warranted. If it is reduced, then again we can observe. And again, if it is stationary, again we can assure the patient ki like that we can again wait, but he is apprehensive. No harm in doing multi-parametric MRI. That.
Sir, in second is if the PSA is like from 4 to 10, we can take other things such as PSA density or
PSA.
Yeah.
No,
So
no.
again,
Before, listen. Before going for MPMRI, all
yes,
the
sir.
causes of rising PSA should be ruled out. Patient had obstructive voiding, number one. PSA is raised from 4.5 to 7. That is only one report. Number two. Number three is antibiotic, how much he has taken and for how many days he has taken. All these things should be ruled out first, because availability of investigation doesn't mean that investigation should be done. As another thing, MPMRI is not available everywhere, and presence of nodule doesn't mean that there is malignancy. Considering all above facts, it is better to rule out other causes and go for MPMRI whenever it is literally required.
Okay.
So now let us clear the other doubts in everyone's mind. Another thing is, suppose if this patient says, okay, doctor, can I wait for another 2 months? Whether, or can you say that you will repeat PSA after 2 months? Ganesh bhai, if the patient says, you will, what advice you will give him?
सर इफ पेशेंट सेज कि मुझे किधर अर्जेंट काम है जाना है वगैरह वगैरह 2-3 महीने के लिए, then with the current finding I would say कि it looks okay, because whatever is the PSA and everything, if at all there is cancer, it is going to be early prostate cancer.
Okay. And as such, he has got a 90-gram
But
prostate.
Technically you can't say कि मतलब हमेशा के लिए late, मतलब this is a question will be asked for evaluation only. So
Okay.
as Mahendra and sir said कि थोड़ा बहुत कुछ ये वो infection, maybe a repeat PSA, this is accepted in most guidelines probably.
Fine.
And
So another question which will be
Sir,
in
sir,
our
sir,
mind
sir.
is,
Sir,
bolo.
why not to go for percentile PSA, free PSA and ratio? Because it is in gray area.
Yes, sir, that's
Correct. Yeah.
Sir, even with a nodal,
जा सकते हैं percentile PSA, age-related PSA, but every time they don't work well. मतलब exam discussion के लिए सब ठीक है.
I feel in this particular patient, because there is clinically suspicious nodule palpable, all these things
Yeah.
would not apply. I would feel in a patient with suspicious nodule in a rising PSA,
I agree with that.
the patient should proceed for a MRI directly now.
That
तो
is what
मेरा
the
एक सवाल
student is
था.
also saying. I think he's right that there is a nodule, so then we should concentrate on
So,
that.
Hiren bhai,
Right.
my was actually in the
Same patient with clinically benign prostate, then maybe
Correct.
pre by total PSA or further observation would be acceptable.
I think
Yeah.
Ganesh Bhai is also saying the same thing.
So,
नहीं.
Gite sir, आपको एक सवाल पूछना है मुझे कि DRE में a student writes one suspicious right hard nodule. So why hard nodule should be suspicious? I am not joking, मतलब I'm seriously asking. मैं पहले पूछ रहा था, my wings had broken because I was walking through the lift area. मतलब there should be some point of view from the examiner. If uro-oncology में मुझे ऐसा बोलेगा कोई suspicious hard nodule, तो I will say कि बाबा you are not good at clinical examination.
True, absolutely correct. So the moment
So
it is
students,
hard, it is
please.
no longer suspicious.
Exactly.
Yeah, if it is hard
No,
nodule,
he-
it's not suspicious.
No, sir. What Ganesh Bhai is trying to say is that there is a nodule or no nodule. Simple बात है.
Exactly.
Yeah, hard nodule. Once hard nodule is there, you have to investigate.
हाँ, मतलब तुम बोलो firm area है, ठीक है मैं मानता हूँ, but suspicious hard nodule मतलब you are not sure of your clinical.
You have to
Yeah.
be clear. Nodule or no nodule. Simple.
Okay, but Maheshwari, my question was, suppose this nodule is not there, and now it was a rising PSA, already antibiotic was given. After that also it was rising, but at that same time on PR there is a no nodule and the gland is 90 grams. So in that case, what is the time limit minimum we should wait, number one, to repeat the PSA, and second, maximum how much time we should give to the patient for the second PSA repeat and then go ahead with the investigation. So these are the two questions which are coming in the mind.
No, sir. I would feel in exam, he has already repeated a PSA once. It
Okay.
is showing a rising trend.
Mm.
Now he can advise further investigations. Now, in
Okay.
practice, things may be different where patient may have his say that I want to delay, I want to wait. We would obviously give choice to the patient what he wants to do. But I think in exam already a second PSA has been done, which is around 3 months apart. The PSA has gone up by more than 80%. It is enough indication that we should proceed further.
And infection is ruled out.
And infection has been ruled out.
Okay. So in exam, if you are already given antibiotics and two samples are they are showing that the PSA is rising, there is no need to ask about the wait for the third time. Correct?
Yes.
Fine. Okay. Swastik, now show the next one.
Yes, sir. Yes.
Just beta, just read because it is very difficult for someone to really see it.
Sir, in exam, they asked to read MRI.
No,
Yes, sir.
not MRI.
Okay.
Means MRI, CT scan also, you can always ask for the report at the end. CT, they expect. Sonography, CT to some extent. MRI,
I think you go to the report directly.
Swastik, show the report.
Yes.
Just read it.
Looks okay.
There is a 1.1 by 1 by 1.2 centimeter
1.2
size,
centimeter. Yeah.
well-defined T2 hypointense lesion seen in the right anterior transition zone of the base of the prostate. The lesion reveals mild bright signal on high B value diffusion weighted image with corresponding to low ADC value. On dynamic post-contrast study, the lesion shows early enhancement and washout on delayed images. The peripheral zone appears normal. No obvious suspicion lesion seen in the peripheral zone. The prostate is moderate to grossly enlarged in size, 5.3 by 5.5 by 6.1 centimeter, 92 grams, with enlargement of the transition zone. The transition zone reveals heterogeneous stroma with well-circumscribed encapsulated nodules. Their hyperintense and hypotense or T2 weighted images indicative of benign prostatic hypertrophic nodules. The prostate capsule is intact and the periprostatic fat gland is maintained. The neovascular bundles are intact. Similar vesicles appear normal. Bladder is partially filled. No significant abnormality. Anal canal, rectum, and bowel.
So now what next?
The lesion corresponds to period. It is written period 3.
Yes, sir.
Intermediate for the presence of clinically significant cancer is equivocal. Biopsy followed by follow-up recommendation is
Further evaluation.
yeah.
Sir, I want to add few points. So at this moment, the student should note few things about the MRI. First of all, the difference between the benign and the malignant lesion on an MRI, the characteristic of both the lesion. Second thing, the pyrade 1 to 5. What are the probability of having cancer in each pyrade? And the last, any difference between the 1.5 or 3 Tesla MRI? The practical question may be asked in the exam. These three.
Okay, can you just tell them in brief so that we can just go ahead?
So exactly, sir, MRI again hyperintense. So it's a well capsulated margins are this time. Is it a diffusion image? I really do not know. Even if I ask, even I cannot read a diffusion image in the MRI. But the characteristic on, if I can see the MRI, like irregularity of the capsule.
DWI shows up.
Yes, sir.
bright area. DWI shows a bright area as cancer, and as you said, T2 weighted images show hypointensity as cancer.
Yeah.
Okay.
Cancer lesion with slight contrast enhancement on a TC. These are features, but slightly to add to what this case is coming. So Pyrites 3 try to PSA density. The whole chart is given in EAU guidelines 23. And if that PSAD is above 0.18, then Pyrites 3 equivocal is supposed to undergo biopsy.
Okay. Fine.
So that
So
is
in this,
below that, and Pyrites 1 and 2 don't need evaluation. If there is further elevated PSA on follow-up, again, no guidelines has said when to follow up. You can do whatever in the follow-up as clinically indicated.
okay. So Ganesh, in this case, in the PR, it was a rising PSA. On PR, the one hard nodule was palpable. Suppose this is showing period 1 or 2 and not period 3. Now it is showing period 3, it is equivocal. So even if there is no nodule, we should go ahead with the biopsy, correct?
सर बट एक चीज है, मतलब वो नोड्यूल पैल्पेबल है, मतलब या फिर नोड्यूल पैल्पेबल नहीं है. नोड्यूल इज पैल्पेबल, कमिंग बैक टू द ओरिजिनल डिस्कशन, एमआरआई हैज टू शो सम. सो इट इज वेरी डिफिकल्ट टू डाइजेस्ट दैट कि नोड्यूल पैल्पेबल है एंड एमआरआई में कुछ दिक्कत नहीं.
ओके, अच्छा, फाइन.
Because one of the old time guidelines which is not so reflected everywhere in European वगैरह because ऐसा discrepancy generally होता नहीं है. But our old time guideline is nodule is palpable, technically go for a biopsy. This many examiners will still remember.
Fine. So in exam, even if it is of 1 or 2,
nodule palpable है, तो it is better to do MRI and probably a biopsy.
Biopsy. But if it is not there is no nodule. Okay. Now if there is no nodule, now, and if there is a period 3, now what? We must go for a biopsy or we should wait?
वो बोला ना सर मैंने, you have to calculate the PSA density. Now, technically, your PSA should be correct. So there should be no infection. Your PSA should have a proper value. So in that bargain, you can do a repeat PSA, which we already discussed. So इसके लिए एकदम fine guidelines नहीं रहते. This is like consensus practice statements what we do.
Okay. So in this case, can someone say, okay, sir, this is equivocal. I don't want to do any invasive therapy at any invasive investigation at present.
But I think in this case, particularly safe answer is to repeat a PSA at 4 to 6 weeks and check the value. If there is infection, जो महेंद्र ने पहले बोला था, अगर infection है तो वो इस दरम्यान में treat कर दे.
अरे खराब ही नहीं हुआ है.
And then,
if it remains the same, and the nodule remains the same, then it is best to go for a technically MRI is already done. It is Pyrites 3. Depends on the PSA density, but you are saying equivocal. Then in the council and then do something.
अरे पानी डाला तो धूल निकल जाती है.
Who is there? Please mute yourself.
धोना है क्या?
Excuse me.
धोना है.
Dr. Mr. Vaibhav,
धोना है क्या?
please mute yourself.
So Mahendra, barabar na? This is okay, I guess.
Yeah, sir. If serum PSA, even the serum PSA remains same after the 2 month and nodule is also there and patient is apprehensive, then no harm in doing biopsy on that time.
MRI we have already done. That's
already done.
Okay, so there are two things that if there is no nodule, you can repeat the PSA after 4 to 6 weeks, and if it is not rising, then we can wait for the biopsy. Otherwise, in the exam, you can also say that I will go for a biopsy. Correct? Either way.
Yeah.
Okay, fine.
So as Sir Pankaj sir mentioned that in this particular case, if nodule is there, MRI is done and it is showing Pyrites 3 at one place, and the right side where the nodule is there. Okay, is it not harm in saying I will do the biopsy after this? Because the lesion and the pyrates are correlating.
Yeah. No. We all agree
Yeah.
that if there is a nodule palpable, period 3, we will say in exam that we have to go for a biopsy. But if the examiner asks you to the candidate that this is period
Yeah,
3,
then it is
it
okay,
is
sir. We
equivocal.
have to wait. We have to wait for 3 or maybe 1 month. We can repeat serum PSA if it is rising or maybe the same. Then with the proper patient counseling and explain that biopsy will result in identifying the cancer, and he may require further. The counseling is important. The patient counseling to go ahead with the biopsy.
Okay. Is it clear to all the candidates, or any question is there? Ask just now. Don't get confused in exam.
Just one thing, if nodule was not there, sir, and this all
Yeah.
the lesion looks in the transition zone, so then also we'll, if pirate 3 lesion in the transition zone, we'll then also advise for a biopsy.
Is it not about the where the lesion is? Is it all about the pyrate?
Pirate. Okay, sir.
तो इसमें PSA कितना था? I missed that.
7.8 something.
7.2.
It was 4 point something 3 months before, and it is 7.8 like that after 3 months.
Okay. Fine. Swastik, go ahead.
Yes.
So what we did?
Biopsy.
Okay, so benign. I just want to add, examiner may ask if the nodule, what else it can be, what else it can be. So either prostatitis or maybe some granuloma. Only these 2 things can have an abnormal PR.
Okay, fine. So ultimately, it is a benign prostatic
Who is
hyperplasia.
talking?
Correct? It is a benign prostate.
Yeah.
Now,
Yes.
the Mahendra and
Yeah.
the thing, Ganesh, the question is it necessary when suppose a nodule is already palpable and this is the report, is it necessary to repeat the biopsy or to do the PSMA PET scan?
So nahi, abhi you have done a biopsy, you have got it normal. Now, if you vaguely also think that a systematic biopsy has missed the cancer, say, for example, in that case, it is again what I said earlier. This cancer is going to be a slightly early cancer, so it's okay. Like I can just repeat a PSA at 6 months. The PSA might jump. It might jump to 12. If it jumps to 12 again, the same thing we have to do. We'll have to then the options are less. They say ki if you have not done a MRI before a prior biopsy, do an MRI before a repeat biopsy. These are guidelines. And then if you are doing a repeat biopsy, slightly better. This thing is Fusion software.
I want to ask one question. The question is that these patients, uroflowmetry is suboptimal for his age and for the prostate. But suppose patient is very symptomatic and he says that you please do my prostate TURP. So if you are going to go ahead for the prostate TURP,
On basis of current biopsy, you have ruled out cancer. So nobody is wrong in doing a TURP.
Okay. So the next we can go ahead with the TURP, correct?
Yes, sir.
Suppose if we don't go for a TURP, then when to repeat PSA, or is it necessary or not to repeat PSA?
You can repeat because this patient particularly is going to keep anxiety with him.
Someone is just I don't know who is.
No problem, but this patient is going to be anxious as always. So it is safer to repeat a PSA at 3 months.
Okay.
Sir, we can also assure the patient that the prostate size is 90 gram and serum PSA is 7. Right, so it can be only a benign part secreting such quantity of serum PSA.
The question is, when will you repeat a PSA?
So, sir, maybe 6 months.
There is no clear-cut answer.
No,
That depends on how the patient is anxious.
Yeah.
Okay, fine. So this patient was symptomatic, and we have done yes, Swastik. So what we have done? So anyway, we have done TURP on him, and we are waiting for biopsy report. Fine. Anyone wants to ask any question? Please ask just now. Ajinkya.
Sir, any cutoff for sir open prostatectomy? Any size cutoff for open prostatectomy, sir? Like this case, 90 grams.
More than 80.
More than 80. So can we offer him?
I don't think so. There is a size criteria. Only the involvement of adjacent organs is the criteria whether to do surgery or the radiation therapy. If it is about the TURP, maybe the current guidelines, what is there, Gaurang Shah sir mentioned about the benign prostate.
Yeah.
But for malignant, I don't think so. Any size is any criteria at present. Only and the radiation or the surgery can be done on an individual basis.
Ajinkya, there is a I think voice from behind you.
Yes, I'll see.
Ajinkya.
Yeah, I'll see, sir. Talking.
Gaurang Shah sir, what is the criteria maximum size of TURP, this thing, benign prostate to be done by TURP?
Benign prostate, now actually we are doing all prostate mainly up to even 160, 180 grams we are doing TURP only, and that also monopolar. We are not doing bipolar. But with the bipolar it is better. Ideally, I think UA guideline says that more than 80 to 90 gram prostate.
90 grams.
Okay.
One has to, means either you do open or you do HoLEP.
Okay.
I think Maheshwari ji, please now this is a case. So you just take over and explain to them that how to go about.
So I agree with you that in exam, if the prostate is more than 80 grams, you should not keep TURP as your first treatment choice. Okay. Now, what are the options? You may say that, okay, the endoscopic options are HoLEP. I am not trained for HoLEP, so I would offer this patient TURP, open prostatectomy, or refer him to a place where enucleation facilities are available. Okay. If the prostate is more than say 200 grams, then definitely you can say open prostatectomy or a robotic simple prostatectomy.
And what is the difference between HoLEP and TULEP? If the examiner asks you, okay, if you are sending the patient to a different center, where you will send?
So basically, you need to just say that I would send out the patient to a center where expertise of enucleation is available. Now, endoscopic enucleation can be done by any energy source. The difference between the energy sources would be some part case selection and some part complications. So say somebody who is on antiplatelet agents will necessarily need to be done by some laser technology. You cannot do a bipolar enucleation in that. Or somebody wants to has a bleeding tendency, then laser would have an advantage. Otherwise, the results of all enucleation procedures are same. The difference between thulium laser and holmium laser. Oh, I'm sorry, my phone is repeatedly ringing. Just a second, sir.
Yeah.
Hello. So the difference between TFL and holmium laser will be that enucleation happens well with both the procedures, but TFL may be a bit slower because it is nearly a contact laser. Thulium laser. So always remember that thulium laser and thulium fiber laser are different lasers. Thulium laser is a contact laser, which is a pure cutting and coagulating laser. It cuts very well. So you don't enucleate it with, you rather resect with thulium laser. Finding proper planes and staying in the planes, carbonization, as very rightly said, is much higher in thulium laser. So many times finding proper planes becomes very difficult. So thulium laser cannot be compared to holmium laser as far as the enucleation capacities are concerned. Otherwise, there is nothing much to choose. So any laser center which specializes in enucleation, you can send the patient for that procedure.
Okay.
Fine. So now, Ajinkya, Rahul, it is clear to all of you?
Yes,
Or
sir.
still you have got any
Yes, sir.
any
Yes, sir.
queries? Clear it now only.
Okay. Okay, sir.
Okay?
Okay.
Fine.
Fine.
Okay. Yeah, okay. Swastik, quick, second case.
Yes, sir. Case
So
2, sir.
someone has asked, IPSS score is mandatory in exam?
Absolutely essential.
Absolutely. There is no question.
You see, when somebody is giving you the history, mentally you should keep on calculating the IPSS score.
And
So
also add two more things. One is a quality of life and even the sexual problems. Correct?
Yes.
yes, so that would be
Yes.
part of the history. But when you are being given the history of lower urinary tract symptoms, mentally keep on calculating the IPSS score. And even it will be a good idea to separate the score into the voiding score and the storage score. So you can say that this patient has an IPSS score of 18, predominantly voiding symptoms. So examiner knows exactly what you're talking.
Right.
Yes.
Yeah. Case 2. Fatapat. Swastik.
Yes, 67-year-old
Ajinkya.
male present with a complaint of frequency, urgency, and nocturia. No history of hematuria or dysuria. One piece score is mentioned. No history of histomation in the past. No history of facial edema, breathlessness, lower limb edema. No comorbidities. On examination, patient responses overrated. Vital stable. Per abdominal examine, no obvious palpable lump or no organomegaly. On DRE, no fissure fistula. Grade 3 posteromegaly. Firm and non-tender. Mucosa mobile. No blood on fingers.
Yeah, go ahead.
His hemoglobin is 13. Leukocyte count is 9,000. Platelet is 234. Creatinine is 1.1 and serum PSA is 3.2.
Just read the report.
The prostate is grossly enlarged. Size is 7 by 6 by 5.6. Volume is 136 cc. Gross prostatomegaly, sir.
Okay. So now next what? What was done after that? Okay, Ajinkya. So now this is a case. Patient has got a retention. Patient has got a prostate which is 136 on sonography. Okay. My question is that in such case, will you like to give catheter-free trial or you will consider him for the prostate surgery?
So depending upon the actually USG findings, like if there is any intrafocal prostatic protrusion or any findings, then I would like to give one trial at least for a trial void for this patient after starting Silidocin 8 mg in this patient.
What is your view?
So I'd like to know, how did patient present with the retention? Like it was acute urinary retention, and how much was the urine drain? And so I can decide whether any patient, and what was this patient's previous complaints? How bothersome were they, and was he already on any medication? Then I can decide later.
Yeah. So just see whether patient was on any medication or not. I think patient was on dutasteride.
Not mentioned.
Not mentioned.
No, sir.
So what else we had done? Any other investigation we had done?
No, sir.
Hmm? We had done any other investigation?
MRI.
Sir, we had done MRI, sir.
Why was it done? Why was it done? I think PSA was high in this
No,
case.
PSA was 3.2, sir.
3.2,
Yeah, yeah.
sir.
3.2, sir.
Initially, yes, I agree.
Okay, okay, sir.
Okay.
I think there is
Anything is
some
clinical
mix-up, sir.
finding?
Maybe PSA ज़्यादा होगा या वो
Hmm.
are these some other patients' reports?
No, sir.
But I'm sure I had seen this patient and his PSA was probably he was on dutasteride, and that is the reason long term. So that is the reason we calculated it is double. This history is not there, but he was on a dutasteride, and that is why we said that it is better before we go for a surgery. Because suppose if I go on an open surgery, then in this case, 2 times, 3 times catheter-free trial had failed, and we had to go inside to do the surgery. If we do open surgery, so that is why we decided to do MRI. Show the MRI report.
Well defined.
So Mahendra, my question is, when the patient is on dutasteride and if the PSA is like this 3.2 or 3.4 and the prostate is 134 grams. So in that case, is it advisable to ask for MRI?
Sir, we have to see for how much time he's taking to test, right? Normally 6 months is required to make the serum PSA
Yeah,
half.
he was on dutasteride since long.
Yeah, so again, if in this case a serum PSA is supposed maybe 6, if it's dutasteride for 6
6.4,
months,
yes.
it is it will 6.4 and having serum prostate size 124 and DRE is normal. I don't think that indicate that is warrants to do an MRI.
And suppose if I am planning to do open surgery, forget about
No, then, sir, I would not
endoscopy.
have done MRI.
Yes, sir.
You will not have done, na?
No, I would not have done MRI.
Yeah. So, what, sir? What did you say?
Yeah, no. Question is that because I may plan for open surgery.
Yeah.
So in that case, as a precautionary, should I do MRI or just go ahead with my line of treatment?
So then that means you are doing open prostate for the benign prostate, not for
Yeah,
the
benign.
Yeah,
Correct.
so benign you can whatever either TURP or whether open you can see, and whatever HPR is there, it will be done accordingly, because pre-operatively nothing is indicating to having malignancy.
Okay.
Neither
So in this
clinical
case,
investigation.
If someone is planning for to go or to treat the patient by open surgery, the only investigation required is to know the amount of median lobe to decide the type of open surgery. If it is already decided,
Yeah,
and
so
that can be judged with sonography. So I don't think there is a need of MRI. If you are suspecting a malignancy and already there is a rise in PSA on the track of malignancy, yes, there is a role of MRI. If you are not suspecting malignancy in this patient, there is no role of MRI.
Absolutely.
okay.
and what are the doubt of having MRI? There's an indication in USG having pelvic nodes like that. Even the DRE is normal, something, just any small doubt of having something like that. But again, can be also infection, nodes can be because of infection. So we have to rule out all the probable causes of these node involvement and then go accordingly.
Fine. So, but I did a MRI. Just show the report. There is a one moderately hypodense nodule measuring 18 into 12 millimeter is seen in peripheral zone on the left side. It shows heterogeneous post-contrast enhancement. Okay, and I think it was a period 4, correct?
Yes, sir.
Can it be period 4?
Yeah. So if it is a period 4, so now what next? Now,
What
as
is the
everyone
difference between
said,
period 4 and
we
period
should not
5?
have done, as everyone says, we should not have done this MRI also. And I also actually now agree that I should not have done. But it's showing period 4. Ajinkya?
Now we have to go for a biopsy, sir.
No, my question is whether to all of you, whether we should ask for PSMA PET scan or go for a biopsy. Because
No, sir, as far as
clinically you are not
exam is
suspecting.
concerned, PSMA PET CT is only for metastatic evaluation.
In this case, actually, look, even if it is there, it would be a localized. So first we'll do a biopsy, prove it, and then only I think so PSA, MA, PET should be done, sir.
No, but PET scan after there is no need to do a PET scan, na? Because PSA is also not very high.
Yes, sir.
Yes.
Depending upon the Gleason, sir, and then we can, if it is localized
grade
and low
group, it
risk, then
comes
yes, sir.
as, if it comes at
No
intermediate
need of
risk
that.
or high
Very
risk,
good.
then we can do PSA, but if it comes low risk, then
Ganesh bhai, what is your view in exam? If something like this happens, how they should answer? Mahendra, you can comment. Mahendra is there?
No, I am here. So,
Yeah.
sir, as I said, the indication of PSMA is based on the Gleason grade. It's a high, intermediate, or the high. 3+3 it is not recommended. So I think the biopsy, after this, the biopsy is the first approach, and based on the biopsy report, we can decide about the PET scan.
Now, my question is, suppose patient says that, sir, I am afraid of biopsy. I don't want to do biopsy. Can you do anything else? Can you do PSMA PET scan? And if it is negative, go ahead and finish off the surgery.
So, sir, then we have to.
Sir, in this case, sir, we can do this free PSA and PSA density because the range is coming from 4 to 10. If we double the PSA for dutasteride, then we can decide on.
But Rahul, density or the PSMA velocity and the PSA ratio is not a 100% confirmatory thing. Okay.
Okay, sir.
What sir is saying, the patient is asking, which is against the recommendation. Okay.
Okay.
It's a patient choice. What is patient is saying that. So in that case, you have to explain what is the right line of management.
Yes.
Okay. Then if you explain the patient, he understood that, and despite of that then it needs to be properly documented, and go ahead, whatever the patient is saying, just tell the patient this is not the right way, proper with the biopsy, better to go with the biopsy. PSM is not going to help anything. It may only misguide us.
At present, I don't think MPMRI or PSMA PET scan will replace the need of biopsy. Maybe in future, but at present, biopsy is mandatory.
Yes.
Yes.
Fine.
Like Maheshwari sir said, that practice is different and exam is different. Exam, you say biopsy, patient may want something else, that is a different thing.
Remember, examiner will make you confused. Okay. So don't get confused. Stick to your guidelines, what you have read, and what your protocol in your hospital.
All of you, please understand. Okay.
Yes, sir.
I am asking you these questions because many times examiner will ask you. He will say that, see, everything is going against this, but you want to do surgery, patient wants it. Why don't you do PSMA PET scan? And if it is negative, you go ahead and do the surgery. So you stick to your guidelines and whatever is you are supposed to say in exam. Fine. Okay. Next. Priyesh, what was run?
Sir, biopsy.
And it showed only the chronic prostatitis, correct?
Yes, sir.
Yeah. Fine. Yes, Ajinkya. Now this is the report. Now what you want to do? 3 times patient's catheter-free trial has failed. And the prostate is 134 grams.
In this case, sir, we'll explain the patient regarding the disease, and I would like to counsel him for open prostatectomy after doing a cystoscopy in this patient.
Okay. And if the
and after the
patient
fitness.
if the patient says I don't want open prostatectomy, then
If the patient doesn't want, then I would like whole up, and I would like to refer him to a higher center when the expertise are available.
very good. Now, if the patient asks you, okay, doctor, I don't
Yes.
want open surgery, okay,
Yes,
and
sir.
there are 3 or 4 different methods. One is a HOLEP,
Mm.
second is a
Yes,
TULEP, and third is the a robotic
laparoscopic or
surgery.
robotic. Yes, yes, sir.
So, what you will prefer? What
So I
advice you
would
are
prefer,
giving?
so from my side, I would like to do a open surgery, sir.
No, he says I don't want open
Okay.
surgery, but these
So
are
the
the 3
best would,
options.
so the best option then would be, sir, laser surgery.
So,
It would be a minimal
you
invasive.
should read the mind of examiner why sir is asking
Okay,
this question and reply, because
You
options are
understand
there:
what?
laparoscopic prostatectomy transfer cycle, robotic
yes,
prostatectomy transfer cycle, laser prostatectomy. Sir may explain detail in this case also. Laser is also one
yes,
of the
sir.
best option. And open surgery, then retropubic Miller's prostatectomy or fresh prostatectomy. So these are the
Fresh
only
prostate.
options available. And if patient general condition is not fit, then some 3-4 more options for a minimal
Yes,
invasive
sir.
type of the
Minimal.
treatment. So read the examiner. Where is he from? What is he practicing? And try to give that answer.
Okay.
So, what sir
So
is saying
again,
is,
let me reframe this question and stretch you a bit more.
Yes, sir.
yeah,
So patient can afford anything and everything. Means he can even go out of India for treatment.
Okay, sir. If
Is
he
there
is
any
affording,
minimally invasive mist therapy which you can offer to him?
whole up would be, sir,
HOLEP is not
best.
mist, beta.
Okay, sir. Missed. Okay.
Minimally invasive.
So minimal invasive also we do.
Okay, let me give you choices.
Okay, sir.
Resume, Urolift, Aquablation. Why? Which and why?
Sir, I think aquablation and
Urolift
urolift cannot be done beyond 70
cannot be
grams
done,
of
sir.
prostate.
अब एक-एक करके
Yes,
बात
sir.
कीजिए, मुझे 2
Oh,
सुनेंगे
sorry.
यार।
Okay, sir. Ajinkya. Sorry.
Sir, the urolift and the aquablation, I think, cannot be done beyond 70 grams of prostate. So best will be resume, sir.
Okay. You have any other answer?
No, sir.
Okay. No, this is not correct. You see,
Yes.
both resume and Urolift, the upper limit of is 70 grams, 80 grams.
Yes, sir.
Okay. Resume is possible beyond 80 grams, but it will need multiple injections, longer catheter duration, and significant amount of dysuria. For a very large prostate, if you have to choose one of the missed treatments, then there are only 2 options. One is aquablation, and second is prostate artery embolization.
Prostate artery embolization, sir.
Aquablation is usually, it is a water jet treatment, and any size prostate can be treated. They have even described there are a series of more than 150 gram prostate treated by aquablation. They say that in that you need 2 passes. Means first time you will do first layer and then you deepen and take more tissue and then ablate that also. So if patient wants a minimally invasive, that option is theoretically available. So this was only a theoretical question to understand whether you knew the indications of various mistreatment. So the only mistreatment which can be done for large prostate is aquablation and prostate artery embolization. The problem with prostate artery embolization is that the result would take a lot of time. The shrinkage of prostate may take as long as 3 months. Your patient is already on catheter and the result is erratic. At best, the result shrinkage that you get would be around, say, 70% at 3 to 6 months. From that point of view, if I have to choose one treatment, that will be aquablation.
Agreed, sir. Totally agreed.
Okay.
So please understand, you people are now in the new era. Okay. Already USI conference has taken place and so many options. So foreigners have, or, speakers have come and explained us all other things. So your examiner might be well versed with all these things and he may ask you this question. So please read more about this and go. Okay?
Okay.
Right, Maheshwari?
Absolutely, sir. Mist के बारे में तो पता होना ही चाहिए, sir. Mist can be discussed in practical. It can even be discussed in theory. Means you can very well have a question on mist in theory. चलो mist को complete करने के लिए what is ITIND? ITIND. ITIND. No idea. Anybody else?
No, sir.
Okay. TIND stands for temporary implantable nitinol device. Okay. So these are such triangular devices which are positioned in the prostatic fossa. There is a tongue-like thing which fits just inside the bladder neck, and the 3 wires are supposed to make 3 incisions at 12 o'clock, 5 o'clock, and 7 o'clock. It is kept in the urethra for 5 to 7 days only. The results around 5-year results are available, which a good response of around 70% at 5 years. So this is one more new minimally invasive treatment which is coming up. Again, at this time, not available in India. Size restriction is just around 60 grams.
So these 3 points, it causes a pressure necrosis.
Yes.
You understand? And that is how it opens up the prostatic fossa.
Okay.
So you should know all these things. Read properly and then go. Fine? Okay. So anyway, we have done TURP on this patient. And we had removed the catheter. Patient passed urine, again went into retention. Probably he had some clots in the bladder. After removal of the catheter, he passed 2-3 very big clots. And after that, he is fine. But in exam, say what Dr. Maheshwari has said. Okay, what is the best option? Fine? Okay, so let's go to the other 2 cases.
Case 3. A 28-year-old male present with a complaint of pain over left flank for 15 days. Pain was sudden in onset, colic in nature, radiating from loin to groin, associated with nausea, and over last 15 days. Relieved on taking analgesics, not associated with hemorrhage. On examination, parabdo soft, non-tender, no organomegaly, no renal angle tenderness.
Yeah, show the investigations.
Yes. Hemoglobin was 14, TLC was 7,000, platelets 4 lakh, serum creatine 0.8, urine protein micro 4 to 6 pus cells in high power field, and 1 to 2 RBCs in high power.
So my question is, if the pus cells are 4 to 6, whether you will consider that an infection and ask for a culture, or you will not ask for a culture?
Sir, 4 to 6 would not be so significant, sir. So, as there are no features of UTI also, sir. So, won't ask for a culture.
So you will start the antibiotics, or you will not start the antibiotics before, if you are doing anything, or for this patient?
Before the surgery, one dose.
No, surgery, we don't know what is the problem,
Okay.
na?
Okay.
Whether you want to, with a 4 to 6 high power field, whether you will start the antibiotics or you will not start the antibiotics. You are planning for antibiotics, or you are not planning for any antibiotics?
So with 4 to 6, we won't.
Gite sir, what is your view on this? In exam, what they should answer?
Male patients.
Sir, 4 to 6 pus cells, and if he had symptoms of infection, better to go for culture, and before culture start the antibiotic. If he is totally asymptomatic and presented with only a pain loin to groin, then presence of 5 to 6, 4 to 5 pus cells. Theoretically, yes, culture is required, but practically, people, if it is not done, also it is not a wrong thing to say in exam. But we have to defend it. Patient is totally asymptomatic infection-wise, TLC is normal. Patient doesn't have any fever. He presented only with the pain, which is referred from loin to groin. So no need of culture. Antibiotic can be started with culture, without culture. So both way it can be defended.
Okay. Fine. Okay. So go ahead. So can anyone see on the left hand side, just expand it and see? Yeah, can you see?
Above that, actually, not that one.
Yeah, can you see that
Radio
opaque?
Yes, sir. Radio.
Yeah.
Actually, above that one more shadow is
lateral division.
So now what you want to do? Will you like to do X-ray or you don't like to do X-ray?
If you're suspecting stone, so we'll do X-ray, sir. And the USG along on this.
No, Rahul, this patient has
Yes,
come to you with colic.
Yes, sir.
What is your next investigation of choice?
The USG abdomen and X-ray KU, sir.
A patient coming with colic, you see, X-ray KUB needs preparation.
Okay, sir.
So, would you be comfortable doing a X-ray KUB without preparation?
No, sir. USG.
What about CT KUB, NCCT?
So first, I would like to do a USG abdomen as a baseline
Right.
investigation and then dissection.
Yeah. So you can say, you can defend, like Dr. Maheshwari said, you can ask for CT KUB also. If you are suspecting, definitely it is the colicky pain and you are suspecting stone, directly you can ask for CT KUB.
No. What I wanted to say was, I'm sorry, आज मेरा phone जरा ज़्यादा ही बज रहा है. What I was trying to tell you was that there is ample study which says that in emergency, whether you do sonography or NCCT, the long-term results for the patients do not change.
Okay, sir.
So even if you want to say, you can say that the ultrasonography is an extended investigation, clinical investigation. So as a clinical investigation, I like to do it and then I will decide what I want to do. And as if it is a stone, I will like to do X-ray QB after the preparation.
Perfect. Yes.
And if they ask you why you want to do X-ray, you can just go ahead. If it is showing stone, just go ahead with the CT scan.
Sorry,
You can
that phone call, one person is repeatedly calling. So what I was trying to say was that in emergency, whether you do sonography or CT scan, the need for intervention, the need for missing a diagnosis, the risk of missing a diagnosis, and the need for rehospitalization of the patient, if you discharge the patient from emergency, is same. So if sonography gives you answer, that's a more simpler test, less invasive test, obviously less radiation, less cost. So sonography could be first choice. If necessary, CT can always be done.
Understood?
Yes, sir.
And second thing is, you can always say, sir, it is an extension of my clinical examination. I like to do. Right. Second thing is, suppose if you, nowadays many people are saying, why you want to do X-ray? Even if you say that after preparation, I like to do X-ray, many people, they will ask you, why you want to do X-ray? If there is a stone seen in sonography, you can go ahead and can do non-contrast CT. So if you want
if
to
there is
defend,
a low ureteric stone, sir, or stone which is well radio opaque, sir, then we would avoid a CT, sir. So that would be one advantage of doing X-ray.
So you can say, sir, in a follow-up, if there are good chances that I may be able to see the stone, almost in 30 to 35% of cases, you are able to see the radiopaque density. And in those patients, it is easier to follow up with an X-ray rather than doing repeated sonography or CT scan.
Yes, sir.
And for the confirmation, you may repeat sonography. Suppose patient has no pain and you cannot see the radiopaque density later on. Then to confirm, you may do sonography. So this is a way to justify. Maheshwari ji, any other you want to tell them? Because
no, sir,
everyone is saying that X-ray is not required.
As Gite Sahib has said, CT scan has an advantage for ureteric stones. CT scan has an advantage that you will be able to pick up other pathologies also. Okay. And it does not need preparation. It's a single breath hold, very rapid test. Okay. So these are the advantages of CT scan. Sonography, advantages, disadvantage, we have discussed. Disadvantage, operator dependent, may miss mid-uretic stones because of gas. Advantage, no radiation, low cost, and easily available. Extension of clinical examination.
Okay. So now, whether you like to do non-contrast or contrast, suppose creatinine is normal, contrast enhance.
So for
CT.
stone disease, non-contrast CT scan should be enough, sir. It is an ideal investigation.
Okay. Swastik. Next. Okay. Show. Just show them. CT scan. Yes.
Okay.
So now you know the diagnosis.
Yes.
Now what you want to do? Just see what is it.
Left-sided upper ureteric stone with proximal hydronephrosis injury with a small.
So regarding your answer that because it's a stone disease, you would like to do a non-contrast CT, just I'm just drawing your attention that in the exam, remember that if it's a repeated stone former, then you should think about it before saying non-contrast. And if the sonography showing that the parenchyma has scars or it's thinned out, or so those cases you may require additional investigations. So just don't blanketly say NCCT. Keep these things in mind.
Very important, huh?
Yes, sir.
So sonography is important. If sonography is showing normal kidney, otherwise, and mild hydronephrosis or hydronephrosis, then you can talk of non-contrast. Fine. So in some cases, you might have to talk about contrast enhance. So now what do you want to do? What are the options? Anyone from the audience, please? Any queries? Yeah, so the question is when to do CT IVU?
But if in USG, sir, if it is showing any thinned out parenchyma, or if you are suspecting any non-functional kidney,
or stagon calculus, sir.
or a
If you are
stagon calculus
suspecting
in
non-functioning, why you do a CT IVU?
sorry, reduced function. Sorry, sir.
First and foremost, let's stop calling it as CT IVU. Okay. There is nothing like CT IVU. You will call it as a contrast CT or CT urography. Okay. So that's my comment number one. CT urography should be reserved for patients who present with hematuria predominantly. CT urography is not a functional test because CT scan is much more, the pickup rate of contrast on CT scan is much higher than X-ray. So as we would say in IVU, that IVU shows opacification at 30% renal function, that cannot be said for CT urography. So if you want to see function, then you do some functional nuclear scan. If you want anatomy, a lot of detailed anatomy is possible on NCCT, especially if it's a high slice CT scan. So if you have access to 144 slice CT, then you really do not need contrast. Contrast can be given if you want the roadmap. So the advantage of contrast is it gives you a roadmap, but do not give a function as an advantage of contrast because CT scan does not predict renal function.
Okay.
So I had said clearly that you have to keep in mind you may require additional investigations. I did not mean that CT IVU, you may need a renal scan also, like sir said.
Exactly.
If you need to do function, you need to do a renal scan. And also you need to understand one more point, that if there are any anomalies, you would like to have a CT IVU. If it's a horseshoe kidney, if your sonography is showing horseshoe kidney, cross-fused kidney, ectopic kidney, then you would want to have a contrast study. So just your presence of mind in the exam is what we are trying to tell you.
Okay, so you have a 11 millimeter upper aortic stone with around, what else do you want to know?
Ajinkya.
HU is given, sir, and the
What you are expecting in X-ray when you can see such a hard stone?
yes, sir.
Approximately, it will be, I think, definitely more than 1,100 to 1,200.
They have given 1400 HU.
Yes,
Yeah,
sir.
already given, na? I knew it. Somewhere it is given. For 1,456. Yes. So what are your options? My question is, can I do ESWL on him?
Sir, we can offer, but the results for stone larger than 10 mm, sir, would be slightly lesser compared to endourology.
Where is the stone?
Upper
Upper
aorta.
aorta.
So, which technique you will use? Your ultrasonography guided or X-ray?
Sir, in sonography, the locating the stone would be slightly difficult, sir.
So you'll do X-ray, and it is in the ureter. What are the chances of it breaking and coming out?
As told before, sir, this is a very high HU unit stone, sir. So breakage would be also difficult. Fragmentation would be difficult, sir. So ESWL would have a very poor.
So will you like to do ESWL? I don't know.
No, sir. For this patient, no.
This question, if they ask in the exam, okay, why don't you go for a ESWL? How they should defend, or whether they should yes.
No, sir. In this particular patient, he is justified in saying no, because the stone is more than 10 millimeters. The stone is very high Hounsfield unit. So same stone, if we make it 900 HU and say 10.6 millimeters, then probably ESWL will become the primary treatment.
Even in the upper ureter?
Even in the upper ureter, sir.
Okay.
So
please
even
remember,
in ureteric calculi, do not forget ESWL. Especially upper ureter, ESWL works very well. Stones up till 10 millimeter and around 1100 HU, you should consider ESWL as a treatment option. The contraindications for ESWL would be associated infection, very obese patient. How will you know that patient is very obese on CT scan? You look for
skin to stone distance. Yes.
Yes. So basically, if that is more than 9 centimeters, the success of your ESWL dramatically reduces. Will you place a stent before ESWL?
Sir, so they are told there is no, by placing a stent also, there would be no change in the stone-free management.
Not needed.
Yes, sir, not needed.
Any patient where you need to put a stent, think twice whether ESWL is really indicated. Okay, so you don't have access to ESWL and patient is not keen on ESWL. What are the other options available?
First would be, sir, rigid ureteroscopy, sir, semi-rigid ureteroscopy, sir.
What do you mean first? Give him one option, better.
Sir, semi-rigid ureteroscopy.
Semi-rigid.
Yeah.
For a stone just below PUJ.
With the risk of going into
counseling, sir,
counseling.
And may require RS.
If the stone migrates to the then I would need RS.
So just don't restrict to semi-rigid ureteroscopy. In upper aortic stone, you say that I may start with semi-rigid ureteroscopy, but I would have a backup of flexible ureteroscopy.
Flexible ureteroscopy.
Okay, sir. Sir, are we just?
It is not just pushback. Many times young men may have very thick psoas muscle which may make access of your semi-rigid ureteroscope difficult in the upper ureter.
Yes, sir. Sir, are we justifying in saying that if the ureter would be tight in like 2 to 5% of cases, so it may just land up in a stenting?
Yes. So whenever we are doing ureteroscopy, the indications for stenting would be if I find purulent urine or if I am unable to access in. My access sheath or my scope is not going in. So never fight, put a stent, come again after a few days. After how many days would you come again if you put a stent?
So after 2 weeks, we can.
What do you expect in 2 weeks?
So the passive dilatation of the ureter due to the stent.
And how much does it dilate?
Exactly. I don't know. How much I don't know.
So they have said that at the end of 7 weeks, the dilatation, it increases by around 1.4 French.
7 days.
The lumen increases by around 1.4 French.
So after 7 days, na?
Yes.
Yeah.
Okay.
Achha, my question is, even I think Ankur, someone has asked, suppose if I can't go up and there is a very tight ureter and I'm not able to do URS, can I offer mini perk to this patient?
एक बार CT वापस दिखाइए सर.
Yeah.
Go back please.
CT दिखाओ.
Yes, you can offer mini perk to the patient. The stone is to the level, it is just maybe around 2 centimeters below the PUJ.
Correct.
So coming from middle calyx and reaching this down the ureter should be easily possible.
And it's nicely dilated also.
Yes, it is reasonably dilated.
So my another question is, suppose if such a case comes, can these candidates say in exam, sir, I like to do rigid ureteroscopy with keeping in mind that it may go, the pieces may go into the calaceal system, and I like to have to do RIRS. If I cannot pass the rigid or semi-rigid ureteroscope, or I cannot do that, or if there is a purulent discharge, I will do degestanting or SOS. If I am not able to go, there is no infection, I will do mini perk.
Sir,
Is it
all these things should have been included in the counseling. Only
Sir,
then,
for
sir.
upper ureteric stone, candidates should not tell semi-rigid ureteroscopy.
Exactly.
Exactly.
And
Nowadays,
as far as your RIRS is concerned, yes, RIRS
Yes.
is the primary option. He can tell.
Nowadays, it is the
Another
preferred option.
digestant, if the purulent urine is there, yes, he can tell digestant. So RIRS, antegrade URS, then mini perk, then DJ with ESWL, all these are options as per the condition of the patient, proximal kidney function, distal obstruction, and other contraindication as per the procedure. But rigid ureteroscopy better avoid in exam.
Absolutely.
Okay.
And counseling and consent should be taken for all.
And you know, one very important thing is understand one thing, that you lead your examiner. If you start talking that I will do flexible, if I am unable to reach, I will do mini perk. You want to take the examiner to mini perk. He will start discussing mini perk. The examiner would ask you where you stop usually. So if you want to play one flexible ureteroscopy, stop at flexible ureteroscopy. Let him ask कि एक्सेस शीट नहीं गया तो क्या करेगा, एक्सेस शीट डालेगा या नहीं डालेगा, कौन सा लेजर यूज करेगा. So he will discuss RIRS. Okay. So now beyond treatment, you can direct which way you want to take the examiner.
Understood?
Yes.
Agreed, sir. Agreed, sir.
So routinely we are doing rigid ureteroscopy because we have got 4.5 French, and earlier, now RIRS is very common and very frequent and very easily we are able to do after digital RIRS. Okay, flexible. But before that, we were doing URS. But in exam, as Dr. Gite and Dr. Pankaj Maheshwari and Dr. Hiren is saying, avoid saying, because you have got RIRS with you. And everybody is expecting that now you can't say that I don't have RIRS because it is not costly, it is easily available, and you can definitely say. So Pankaj, Pankaj
say
Maheshwari
that
has said, don't say PCNL, say mini PCNL. Yes.
yeah. Suppose you don't have RIRS and you are
Yes, sir.
operating somewhere in a center where there is no RIRS. Ureter is good and the stone is in upper ureter as it is shown in CT.
Yes, sir.
Can you do some additional maneuvers to see that it doesn't migrate because you don't have ESWL also?
So the side which has the stone will put that
So,
slightly. Head would be
patient will be in a ADI position. Will have asked anesthetist to give Lasix before starting, or you can use some stone chopping for the baskets before going ahead with the breaking of the
Okay,
stone.
now you held the stone in the basket and you're trying to come out and you got stuck. Now what will you do?
Sir, basically we'll keep the basket there only. We'll come out with the wire of the basket sideways, and we'll go once again to the side of the basket.
So that need not be done if you're using the correct size basket. So if you have a 1.7 French basket, you can use laser by the side of it. It goes in the URS. Try it next time. Use the basket and put the laser fiber along with the basket. It goes.
Yes, sir.
If you don't use the correct size, then you have to come out, leave it there, go by the side of it. Okay.
Side also.
So you should know about that. Secondly,
Any other disposables which will prevent pushback?
Yeah, any other anti-migration device you know? Anti-migration device.
No, I just feel
The
like
stone
eating
cap,
more actually.
Stone? Somebody's talking in the background.
Tanvi,
It's not called a stone cap. It is called a stone. Sorry?
Cone.
Cone. It is called a stone cone. Correct.
Umbrella or cone.
Yeah, it is
Yes, sir.
from Boston Scientific. It looks like zebra wire. If you
It goes beyond.
put if you put the nitinol core, if you engage it, it becomes like a cone. So it prevents the migration. Yeah.
Who had devised the stone cone?
Segura.
No.
No.
Drettler.
Okay, sir.
So it was devised by Drettler, and the major studies, initial studies were done at MPH Nadia. Okay, so the initial studies are in the name of Drettler and Dr. Mahesh Desai. Anything else? What is backstop?
It's also one of the devices for preventing the stone migration.
Obviously. So what is it?
I've never used it, sir.
Nobody has used it.
Yeah, so somebody has written in the group, the gel gets solid.
Yeah.
So this is a gel which you instill above the stone. At body temperature, it becomes solid.
Okay, sir.
So it will hold the stone. It will give resistance for pushback of the stone. Once you have done with the procedure, through the ureteric catheter, just flush ice cold saline. It will dissolve and come off.
Fine. So some people say head up. I don't believe in giving Lasix in the beginning. Because if you give Lasix in the beginning, it will cause more of the hydronephrosis and the upper ureter may get dilated. Stone may be pushed up. So it is better at present not to give that. When you have started breaking, I
No,
think
I'm
that
talking
time.
too much about this.
Tanvi,
In the end, as I told you, they reformed cranial punishment also.
I also don't like using Lasix, sir. I feel the bladder also becomes full and intrarenal pressure also rises.
no, I'm using, but I like to use it little later.
Yeah, that's what I said. Even I don't use it in the beginning.
So, Gite sir, Pankaj bhai, in the exam, should they say talk about this maneuvering?
Let's not talk about Lasix at all, sir.
Okay, fine. But head up
I
is
also
okay.
agree. I agree.
Agreed with Pankaj. Agreed with Pankaj, sir. No need to say anything about LASIK.
Even
And
I think
if examiner ask also, better not to tell. I will give LASIK.
Okay.
Okay.
So
Fine.
if I have to prevent pushback, head eye position, reduce the irrigation pressure, then use of basket, use of stone cone, and just for completion's sake, backstop.
Yeah.
So these
And
are
the
five
choice is,
things you can talk of.
yeah,
And
and
if
the
you
choice
find that it
between
gets pushed back, then go up and use a flexible scope. Okay,
now,
there is a question from Mr. KD that in case of an impacted mid-diuretic stone not allowing even guide wire to go, what are your options?
Will look if nothing is going, sir, and we can try a smaller size guide wire if that is not going. And better to divert the
a guide wire is not going beyond the stone, but you can go up to the stone, no? Why you want to divert?
First, visualize the stone, sir. If it
Yeah,
is
go with
possible,
a
sir.
small scope, go there, make some
Visualize the
space.
stone.
First, put in a guide wire.
Try some, sir, energy source like a lithoclast, if it is possible to break.
Arey,
If
laser
it is
is there,
not
na,
possible,
Baba. You will use laser, fragment the stone, make a little bit of space. First, put in your
Yes,
safety guide wire, come out again, and then complete the job.
So again, the answer to this will be that one, you will use a hydrophilic glide wire. Okay, that has a tendency to find space. You would do a contrast study to find the passage well, and then use a hydrophilic glide wire. If it works good, sometimes say, if not, then go up with a small ureteroscope, break, make space, put a wire, and as Dr. Hiren Sodha has said, come out and go in again.
And before doing this trial and errors, better be ready with placement of PCR also.
PCR.
Absolutely. If nothing else works, nephrostomy. ये क्या लिखा है अंकुर जी ने? लेजर 1/10 फ्रेगमेंटेड.
And don't say I come across one student, I will pour the stone and place the digestion through that stone. Don't say such things in exam. Your boss may have tried, as sir has told, some partially your boss may have fragmented the stone, made the space and place the digestion. Probably time is more required. That candidate may not have understand that procedure, and he told in exam in front of me, core the stone and try to place the digestion through the stone.
Through the stone.
So that is a very dangerous answer.
okay, can we go ahead with the next case?
Yes, sir. Case 4. A 54-year male present with a history of LUTs and left leg pain on and on over 1 month. Pain was intermittent, colicky, radiation from left loin to groin, moderate incest, and really don't take medication. No history of hematuria, fever, chills. No history of instrumentation in the past. No history of weight loss, facial swelling, breathlessness, or lower limb edema. Hemoglobin was 13. ELC was 10,000. Create was 0.9. X-ray is
बताइए सब क्या है एक्सरे में?
Multiple stones on the left side.
One suggestion: make a system of reading the X-ray.
Yes, sir. So
Okay, there are a few things you should start talking subcortically while you are thinking about the correct answer. कि पोजीशन कैसा है, प्रिपरेशन कैसा है, एक्सपोजर कैसा है, ये चीजें बोलते रहिए, so examiner doesn't feel that you are wasting time. till you are looking at what all the urological findings are. So what X-ray is this, the right one?
The right one is
KUB, which are
the KUB only,
the
sir,
entire.
as
So
it is showing
what
the
should be the
pubic
extent of a
symphysis.
X-ray KUB?
Pubic symphysis should
Pubic
be
symphysis.
from the crest of the diaphragm to the up to the pubic symphysis.
So it is not a complete KUB.
Complete KUB.
Okay, ठीक है. चलिए बताइए, आप बताइए.
So given X-ray is an X-ray KOB. It is well positioned, well exposed with slightly poor preparation. We could identify the visible bony architecture appears to be normal. Could identify a large radiopaque density lateral to the L5 vertebrae, and one more radiopaque density lateral to the spinous process of the L1 vertebrae.
Okay.
And the other X-ray, it is not visible.
Hey, anything else you can make out in the right view, right image?
So the stones, or the radiopaque, it is taking the shape is.
How much is the heteronephrosis?
Can you see on the right hand side? Can you
Yes,
see
yes,
in the
yes.
left hand side?
It is
upper
reaching
calyx?
up to the this.
So don't say heteronephrosis, say that the renal silhouette appears enlarged.
Enlarged.
So both side renal silhouette appears enlarged. There are multiple large upper ureteric calculi and probably a small upper calyx stone.
Yes.
Okay. Right side cannot be commented because of large gas overlying the right kidney. So right silhouette also looks big, but I can't see any stone on the right side.
Yes.
डॉक्टर गीते, मैं एक चीज पूछना चाहता हूँ. Are you there?
हाँ sir.
He was describing radiopaque density at L5S1. So should they be doing this MBBS level description, or should they directly say that upper ureteric stone seen?
Sir, they can directly say that the stone is in the upper ureter, mid ureter, or lower ureter.
हाँ.
Let examiner ask you what is upper ureter, what is mid ureter, what is lower ureter.
Right.
And another thing is here the stone configuration. Probably there are two stone. One stone is obliquely placed. The size of the kidney is the shadow of the kidney shadow is like very large.
Yes.
I may not be surprised if it is a PUJ with stone.
Possible.
Upper ureter is the first, but second, it is a dilated pelvis and stone. There are two stones. If you see the configuration.
Yeah, there are minimum two stones. Yes.
Yeah, so that can be another option. Can it be a PUJ with stone? Yes, it can be a PUJ with stone.
Can these be lymph node calcifications?
Sir, it is along the ureter. If you are asking me, if it is along the ureter and in the line of transverse process of L5 vertebra, probably more chances of it is ureteric stone or stone in the urinary system than the calcific lymph nodes. Then there are only two calcific lymph nodes at that particular site, and the rest of the site there is no because calcification is generalized procedure.
Usually speckled and multiple. No, ये जो lower वाला shadow है, why this thought came to my mind was that the lower shadow is not along the line of the ureter. Among the
it is oblique, sir. That's why I'm keeping that PUJ option. We'll see after doing them some.
चलिए आगे बढ़िए सर, क्या चाहते हैं next? What next?
Like creatinine was normal, sir.
So he showed X-ray KUB directly. Did you not ask for a sonography?
So like to have the ultrasound of KUB.
Why now? Now why do you suddenly think of it? Thinking of these two large stones, do you think what would have happened to the parenchyma?
I mean, this, we can say CT urography in this case, sir.
Yeah.
Yeah,
You can.
Because drainage pattern also will get it.
Given plates are off.
That's very interesting. The sonography image doesn't match the X-ray image.
So your presumption was right.
Yes.
Swastik, do we have second X-ray?
The other X-ray, yes, it was there, sir, but it was not seen on that X-ray. The pelvis X-ray.
Sir, one X-ray.
CT.
No, what happened after this sonography, and when I asked for a CT, I was confused. So I asked patient to get another X-ray. Show the CT scan. Beta, show the CT scan. Go directly now. Because patient had lower intake symptoms. Okay, chalo. Anyone in the audience, please comment. I don't want Ajinkya or Rahul to answer. Please write your answer.
Interesting.
Rahul, you can talk now.
Yes. Yeah. Contrasting. This is a contrast and CT scan of the abdomen plus pelvis, sir, with the right side. Right side it's a normal kidney with normal prompt excretion seen, and left side it's a delayed excretion seen with the stone seen the level of.
So the representative images of the abdomen pelvis contrast with the delayed images. It could identify the right kidney as prompt uptake and prompt drainage, whereas the left kidney there is mild hydronephrosis, but there is radiopaque there is a calculus in the upper ureter, where there is kinking of the upper ureter, and it could identify one the bladder is distended when identify right side a small diverticular narrow neck.
What do you mean when you are saying prompt opacification and excretion? How do you see that on CT scan?
Good excretion on.
Okay. Because these are terms used for IVP. These are not used for CT scans.
Okay.
So what about bladder? What have you said about bladder?
Diverticular on the right lateral also.
So it's a large capacity bladder, thickened at some places, and a big diverticulum with a looks like an open neck.
With high post-void residue.
Yes. Interesting.
No, 16.
So now what was that calcification? It is not matching with this, no?
No.
Swastik, just show the report.
The left kidney is diffusely bulky, measures 13.2 centimeter in long axis and reveals mid-delay nephrogram. A 9.6 by 6.8 by 9.6 mid-sized calculus noted in the upper calyx with HU of 1650, and another 3.2 by 3.7 by 3.8 mm calculus noted in lower calyx with mean HU of 550. Moderate dilatation of pelvic system noted with adjusted perinephric fat stranding and thin rim of perinephric fluid, which reveals patchy contrast extravases on delayed excretory phases. A 9.1 by 11 by 115 mm sized calculus noted in left upper ureter just distal to pelvic ureter junction at L3 vertebral level with mean HU of 1630. The ureter distal to the calculus is mildly prominent due to over-distant urinary bladder.
Bolo. Bolo bhai. Now next what?
So I would like to counsel the patient regarding the CT report and feature which may be suggestive of pyelonephritis. As counts are also high.
Patient is saying X-ray is showing stagon calculus, sir.
Sir, CT is more accurate and sensitive in diagnosing a stone compared to a X-ray. So I would, based on the CT report, I would trust the CT and then go ahead with the further line of analysis.
No, but you have to explain him like why X-ray is showing.
It may be a false reading because of some calcification.
So second, no, what? Don't say false reading.
Okay. Due to any other calcification other than
so other calcification, most probably it may be a lymph node.
Lymph node. Yes.
And then ask him about the history of tuberculosis. Correct?
Yes, sir.
So now what you'll do?
I would like to counsel him for first stenting on the left side, if possible. If stenting is not possible, then I would like to do a PCN in this patient. Sir.
Why you want to do stenting?
Whereas there is a thin rim of fluids in.
Pardon?
Like extravasation. No. Thin rim of perinephric fluid is there, so there is extravasation. So that would be suggestive of some features of pyelonephritis. Oh.
So extravasation. No, my question is if there is extravasation.
Yes, sir.
That means what? Why there is extravasation?
Due to infective cause, maybe.
Only infective, or it is a totally impacted stone?
Or a second would be an impacted stone which has got this extravasation.
So if it is a totally impacted
stone,
sorry, sir.
How would impacted stone cause extravasation?
Due to back pressure changes.
No, you see, in this patient, you have given contrast. Okay. All contrasts are diuretics. Okay. Already there is an obstruction, a high pressure obstruction. When you give diuretics, the intrarenal pressure increases. That causes fornical tear and perineal fluid collection. Okay. So that is why in obstructive uropathy, in acute, especially in acute obstructions, you try not to do contrast studies.
Not only that, normally earlier we were giving Lasix in hydration therapy, but in such cases you should not give hydration therapy also if you are suspecting total obstruction, because as Dr. Maheshwari said, it can cause all these problems.
So I don't think this is a sign of infection. This is just a sign of significant obstruction.
So now, what are the options? Yes. Rahul, what are the options? Anyone on the chat? Can you suggest?
Sir, in this patient, sir, patient presented with LUTs as well as pain. Lower unit tract symptoms are mostly of storage symptoms. And though the Euroflow was again a suboptimal type, and he was again having a significant post-viral, so we'll have to deal with two conditions. So one is the lower tract, that is he has some obstructive flow, and as well as the diverticuli, and also there is an obstructed cal, which is causing the dilatation as well as kinking of the upper ureter. So first, I like to go ahead with the management of the stone. So I'll go ahead do a cystoscopy. I'll try to pass a guide wire, and with the guide wire, if the king to ureter gets straightened, then I can go ahead and then try doing a semi-rigid URS and breaking that stone. If not possible, and if the stone high likely chances stone might pass into the pelvis, and then I can keep my flexible URS also ready if required.
So someone has asked about we always do RGP before doing rigid ureteroscopy. What is your answer? Will you like to do
No, sir,
RGP?
not always.
But will
The
you like
CT
to
as
do RGP?
well,
Not always.
CT as well delineated the lower ureter, pubic bladder, sir.
No. Will you
Again,
like
a
to do RGP?
suggestion. Again, a suggestion.
Yes, sir.
In exam for RGP, don't say no.
Yes.
Okay. Because before doing any endoscopic procedure, I want to have a roadmap, and retrograde pyelogram is a very good roadmap.
Okay.
So don't say no in exam.
Until and otherwise, if you are expecting the system is infected clinically,
Yes.
answer is yes. RGP is better to do RGP in each and every procedure, ureteroscopy, before doing the ureteroscopy, as Quaz is already told by the sir. Anatomical roadmap.
So things like RGP, things like safety wire, don't say no to these things.
Yes.
Always.
Now this is 15 millimeter, and then another one is almost 1 centimeter, and there is a lower calaceal stone. So what will be and this is a hydronephrotic kidney. The stone may be impacted. So what are the options, and what is the best in this patient? If the examiner asks you what is the best bet on this, which you like to do? Patient tells you that you just finish it.
If you want to finish it in only one go, then best would be as a mini pump in this case. It is a dilated system. The stone size is also 15 mm.
Yeah. So you can only justify that it is an impacted stone. It is a large stone. Even the Hounsfield unit is also very high. Okay. So there are good chances that by doing RIRS, we may damage the ureter because there may be a kink. So if such cases are there, I will like to do mini PCNL.
Yes.
Can you do normal PCNL on him? In exam, can you say normal PCNL?
Sir, we can say, but for removing a stone of 15 mm, we would not be justified in putting such a big amplitude sheet and do a normal PCNL. Sir.
So just a small suggestion, the better term
Yes, sir.
will be standard PCNL. Okay,
24.
and how do you differentiate between standard and mini PCNL?
The size of the amplitude. So standard would be
Depending upon the
standard, sir, would be more than 24 French, and mini PCNL would be 16 to 18 French.
Right. Less than 24 is mini and more than 24 is standard.
Standard, yes.
Are you aware of any other PCNL systems like ultra mini PCNL? What is that?
Ultra mini, sir, I think less than 12 French.
12 French, sir, is ultra mini PCNL.
Okay.
And micro PCNL is less than 6 French.
Okay.
Yes.
What is super PCNL, super perk?
Super perk is
10 to 14. 10 to 14.
flexible. No.
Super perk, the difference is not of size, it is of the associated suction.
Yes, that's it.
Okay, so the size is like a mini PCNL, but there is a suction there in the access sheath, in the implant sheath, so that the
connected with
an
the
Yes, somebody has written PCNL with suction.
Yes.
So, question to Dr. Gite Maheshwari ji. Suppose in this case, if the student says directly mini PCNL instead of RIRS, can he justify?
जरा इमेज वापस बताइए साहब. Please go back and show the image. Hey, not this one. Before. Yeah, this is okay.
No. You want CT. CT scan. Just show CT scan.
CT दिखा दो CT.
हाँ. One after that. हाँ. Yeah, this one. So there is upper callus stone also, and there is this.
So mini PCNL is possible to justify, sir, but still I would feel the first treatment option remains retrograde.
Fine, because see the ureter is so much kinked on the left hand side.
Sir, instead of kink, we would better say tortuous. And then we can discuss ways of straightening the ureter.
Okay. Fine. Okay, so keep the options open. And if the examiner asks you, you can justify whichever method you are comfortable and explaining. Fine. Any other questions from the audience?
Sir, in this
case, diverticular, sir.
Yeah, see, we have already. Yeah, we are already done the investigation for his LUTs, na?
Yes, sir. So he has, sir, more of voiding LUTs and a significant post void.
So Manpreet is, first of all, let us finish. Manpreet is asking what are the different ways of straightening the ureter.
So one is with the guide wire.
Second is abdominal pressure.
But how the guide wire will go? Guide wire will go there and will get kinked. It will not. It is not going. Now what you'll do?
So put pressure over the abdomen. That will also cause some straightening of the ureter.
So second will be a head low position. In head low position, kidney tends to move away and ureter tends to straighten. And third will be somebody trying to pull the kidney up by abdominal compression.
Yes.
Okay. If none of these things work, you can go up with the ureteroscope and find passage and put a wire under vision.
Because what happens that you have tried to blindly put the glide wire, it will go, in the straight way only. So it may not go into the right pathway.
Yes.
So that is why you under vision you can try it. Suppose if it is the kink is not getting, you are not able to overcome that tortuosity or whatever when you go inside, you see that the ureter is so oblique and the opening you cannot negotiate. So then what you'll do? You have got everything with you.
PCN sir, then percutaneous neck systems. To
No.
divert the.
You are saying that you want to
flexible scopy.
Flexible, na? You want to straighten the ureter, na?
Yes.
So you okay? Another, yes, Abdul Salam is saying you put a 2 guide wire. Okay, that also you can try.
Yes.
So in this patient, because the upper tract is not very much dilated, RIRS should be the first treatment option, filling which mini PCNL is always there.
Okay.
As far as the
So
divertical
that,
is concerned, what were his symptoms?
He had LUTs. If you see,
More
I
of
think it was 12 by
storage.
that is
11 by 8.
yeah. Dr. Gite is saying try to straighten it. I don't know. That's one way. Try to straighten it by way, sir.
All the methods what sir has explained, that is pushing the kidney and try to straighten the ureter on a antegrade or retrograde glide wire and try to place the ureteric catheter and change it with zebra catheter. Another is directly do a scopy with small ureteroscope, go there and place the wire under vision. These are the ways of straightening the ureter.
Absolutely, sir.
Sir, in this case, at this extravasation was present. So, can we have to consider that in the treatment option, in the treatment decision making, or it won't be a problem?
Unless I see very clear extravasation, I would not give much weightage to that.
Okay.
At least in the images shown, I could not make out the extravasation.
Yes.
Means suppose somebody has a urinoma or a subcapsular collection, then the treatment becomes completely different.
Yes,
but a thin film of
Preoperative extravasation, maybe it may be minimal, but if your duration of surgery is probably size of the stone, or your duration if you are requiring is more than an hour or two, then that extravasation will get increased. So if the stone is small, if you are going in and coming out immediately, no issue. Don't worry about extravasation until otherwise that is causing some clinical symptoms. But if the suppose for example large 2 centimeter stone size of the stone, RRS requiring hours or more than hours, then using the irrigation under pressure, and already that back channel is already open, so it will cause more extravasation compared to the normal routine procedure. So think in such situation, try to place the wire first to resolve the extravasation and go for the procedure. That's what I mean.
So just to add to sir's answer, very nicely has said, if it's a large stone burden, then definitely you must not keep on going on and on. Secondly, good antibiotic coverage, no pressure irrigation. That is a very bad thing because that will create complications. And good placement of digestant, so that if there is no distal obstruction, proximal heals very well.
बोलो तुम्हारा कुछ क्वेश्चन स्टूडेंट्स एनी क्वेश्चन फ्रॉम योर साइड
सर थोड़े बहुत क्वेश्चन एग्जाम में पूछने के लिए भी रहने दो हमारे लिए
should access sheet be yes Raska should access sheet be used in pre-stented cases only or can be used in primary case also? We use it in primary case also. If actually in pre-stented, even without sheet you can go inside very easily.
So the answer to that is that you need to calibrate the ureter. First, you go up with a 7.5 French scope. If that goes in smoothly, then you can use a 9.5 access sheath comfortably. Most of the times, even a 10 French goes in. And if a 8 French ureter scope goes in, then 12, 14 also can be used. So calibration is important. If ureter scope is not going in, then definitely you must not try to push the access sheath in.
So you got your answer?
Yes, sir.
Any other questions?
Yes.
Dr. Bala, apna Gite sir, whenever he is an examiner, all the questions he's going to ask, you will get an answer over here now.
And the result is 100%.
Bas.
पहले ही बोल देना कि सर हम आपकी क्लास में थे.
So पंकज भाई, आपके दिमाग आपको कोई क्वेश्चन याद आता है कुछ? Because these are the commonest things they are going to get today. What we have discussed.
I think we have discussed quite good and enough.
Quite a good. Yes.
क्योंकि देखिए सर, वैसे तो it's a unending topic. Means we can discuss complications of RIRS. We can discuss what are the multiple situations that can arise. Okay, so if your interview goes till then be ready for a gold medal.
Yes. So that to all, every time we have discussed different cases and we have done all these things. This was basically, we wanted them to last time refreshment and we wanted them to ask the question, whatever the doubts they have got in their mind, as far as the exam is concerned. You know, what are the questions they may be asked, or if they have got any confusion regarding the answer. So I think we have cleared quite a lot of things, and we stop here. All the best to all the students. Today 50 students have attended. I'm sure out of that 25-30 must be exam going. The exam starts on 8th. I think first exam is on 8th and 9th, and then it is, I think, 12, 13, and then 20th.
Yes, sir.
So all the best to all the students.
Good luck, do well.
Yes, sir.
Good luck to all of you. Take care. Good night.
Thank you, sir.
Good night, sir.
Good night. Good night. Thank you. Even though you were traveling, you have attended. Thank you.
Thank you, sir. Thank you, sir.
Yeah.
Good night, sir.
Sir,
Good night.
please end the session, sir.
Good night.
Okay. Shall I end it?
Yes, sir. Yes, sir.
Okay.